Good morning, everyone. Welcome to the Medicaid monthly virtual meeting. We will pause for a moment to allow folks to come in from the waiting room, and when that slows down, we'll get started. Okay, good morning. My name's Veronica Judy Cecil. I'm Senior Deputy Commissioner for the Kentucky Department for Medicaid Services, and I'd like to welcome you this morning to the Medicaid monthly virtual meeting. We've got another really great agenda today with information that we hope you find helpful. And we appreciate you taking the time to be with us today, or if you're watching this, the recording, for taking the time to listen in. Next slide, please. We have a lot of our regular updates, and that include Medicaid renewals, state-based marketplace, our 1915 I-RISE initiative, our 1915C child waiver. Today, our sister spotlight is the Department for Aging and Independent Living, who's going to be talking about emergency preparedness. So we appreciate having Dell with us today. We have our Healthy Kentucky Home Spotlight. Dr. Terrio is back with us to talk about home emergency preparedness. And then we're going to give you an update on HR 1, which is the new federal law to require certain work and community engagement activities and some other eligibility changes. So let's get started. Next slide, please. Next slide. So this is the snapshot we show at the beginning of this part of the presentation. As you see, we're continuing a slight decline as part of the redeterminations that are happening that restarted after the public health emergency unwinding. And so we'll see that little dip, but we'll talk a bit more about what we're seeing in those numbers. Next slide, please. This is February as the last month that we have completed our renewals. In February, we have that a little bit larger number of 139,700 individuals did go through a renewal. We have a very high, again, approval rate. That's about 86% at 120,604. We did have to terminate 18,338. And then that pending bucket of 758, just as a reminder, those are folks that we were unable to complete their processing. The state was unable to complete the processing of their case. And so because they're pending, they do cross over into the next month and maintain eligibility until the state takes action. Next slide, please. This is showing you based on age range. On the right-hand side is those who were terminated. On the left-hand side are those who were approved. As you can see, we, just to point out, and we'll talk about these a little closer, the blue is age 0 to 6. The orange is age 7 to 18. You're seeing a larger number there because, as a reminder, we did pause child renewals until June last year. And so they're going through, many child cases are going through their first renewal since the public health emergency. So those numbers look a little higher because this is the first time they've gone through a full redetermination. Next slide, please. So as we dive a little deeper into child renewals, because we are watching those very closely, it always is concerning to us to see a child losing their coverage. And so we do want to make sure that that is appropriate, that we're not having children drop off of the program. If there's something we can do to try to prevent that, if they are otherwise Medicaid eligible. This is showing you the approved is green, the terminated is red, and it shows you the three buckets that we kind of look at as as the children are going through the renewal. So on the far right, you see passive with no RFI. As a reminder, passive, it means that we were able to go out and check all the various data sources and determine somebody eligible without them having to take any action. So we're able to verify their eligibility through those data sources, and that's called passive renewal. So we were the majority of the children. We were able to passively renew, and we always have a very high number. Kentucky is somewhat of a leader in their passive renewal rate, so we do kind of stay up there in the 80 percentile for passive renewal. The middle bucket there, you see it says passive with RFI. That means that we did go out there and try to perform that automatic renewal, but there's just one little bit of information that we need for the member to verify. So they get what's called a RFI, or request for information, just to verify that one little piece of it that we need. And then on the far left there, you see active renewal, and they are the ones that we always attempt to try passive renewal on everyone. But if there's a major change in the case, or we do not have the ability to go out and check those data sources for those folks, then they drop to what's called an active renewal. They get a pre-populated renewal form, and likely there's again various pieces of information that we need, or documentation that we need, to be able to move forward with making that redetermination. It is generally, as you see in both the active and the passive with RFI, the termination number is a little higher than approved. And generally that's because of not receiving a response. Let's go to the next slide. So this shows you, with those child terminations, the reason. And that big number there, 9,661, is for failure to return the form of verification. We always encourage folks to return the form or respond to the RFI, because the child eligibility limits are higher than an adult. And so while there are members in the household who may no longer be eligible, the child might still be. And so we always encourage those families to return those forms so that we can make that determination. But unfortunately, despite lots of outreach, we do see a failure to return as the number one reason for a termination. The smaller bucket there at the bottom, the other reasons, is generally because the family or the guardian has requested that the child be removed from the program, and that's likely because they have other coverage through maybe their employer, or they possibly have coverage some other way. And then ineligible for benefits are those that we've actually determined that they are no longer eligible. Next slide, please. So currently, there's still the 12-month renewal for Medicaid members who are subject to a renewal. We're constantly urging members that if there is a change in their address or their phone number or their email address, to report those to us so that we can contact them when they are up for renewal, or if there is a reason that we need to reach them because maybe a change of circumstances happened that we've been made aware of. We do send reminders multiple times prior to that renewal date. They can check their renewal date, and there are various ways to do that. They can call the Connect hotline, that number 855-459-6328. They can go into a Connect portal, their self-service portal, and they can always find the most up-to-date information about their case in Connect. So we do encourage our members to create an account so they can keep up to date that way. And then providers, we always ask providers to check the renewal date in Kentucky Health Net. When the member's coming in for an office visit, maybe you can remind them that they've got a renewal coming up, or perhaps they're in the month of renewal, and make sure that they understand whether or not they need to take any action. So again, just Just encouraging folks to respond, to keep their information updated, and to immediately reply if they happen to get terminated, but believe they are still eligible. Next slide, please. We've created a lot of communications to help support members that are navigating the renewal process. These communication materials are available on our website, the medicaidrenewal.ky.gov website. And we ask just anybody, if you're an advocate, if you're a provider, if you interact with Medicaid members in any way, that you can pull these down, you can post them, you can share them. We do encourage the use of these and the wide distribution of them to help members navigate the process. Next slide, please. And then for children in particular, we created a toolkit. There are some specific to the child renewal process to help families navigate it. There's an FAQ. There's information to help schools support members and families that are navigating the renewal process. Again, these are available for download, and we encourage you to do so and to share them. Next slide, please. This is our website. This is where you'll find the recording of today's monthly meeting, as well as past meetings, presentations, the renewal report that we base the slides on today. The information are based on the CMS, Centers for Medicare and Medicaid Services reports that we submit monthly to CMS. So all of those are on here if you want to look a little bit more into what's on those reports. We have frequently asked questions on here and a lot of other really great communication materials on this website. Next slide, please. Okay, now I'm going to see if David Veery.
Good morning.
Good morning.
And good morning, everyone. So from the state-based marketplace, these are the ACA or qualified health plans. We have had, actually, it's closer to 4,500 by this morning who have terminated their coverage since the end of open enrollment. Unfortunately, this was expected. It's less bad than maybe we thought, but we are concerned that while some of these folks might be moving on to Medicaid or employer-sponsored insurance or something like that, we fear that many of them are just simply going uninsured right now. And we're doing everything we can to make sure that people are making the best decision and not making a decision that might come back and be harmful. As a reminder to everyone, just because you get sick is not a reason to then sign up for private health insurance. So there is a number of concern, but we're doing everything that we can, and we sure thank everyone out there for all the efforts that you're doing. Commissioner spoke about RFIs, requests for information, and they've been very difficult for the people on the marketplace side as well as Medicaid. Rules changed where people were given less time than they have been in years past, months less time. So a lot of people didn't get it in on time or got the wrong form in and that kind of thing. And we've had a lot of abrasion with people seeing their the amount they owe for the month spike all of a sudden because their tax subsidies went away. There's a fix for that. We're working with folks to get it put in, but the same drum we're beating here is if you know people, get them to get the documents in and get them in early. Provider networks and high deductibles remain challenges. All of the plans offered through Connect are HMOs, so they have small networks, and we are working with people on the one-to-one basis, but also through our advocates to try to get people to reach out to their issuer to find out where they can get care. It is a legal responsibility of any insurance carrier to help you find a specialist that is in your network. It might not be the doctor that lives down the street from you, but they're here to help, and we are as well. We are starting to see, have already seen a huge increase in the amount of people asking for exceptional special enrollment. These are special enrollments that people are asking for that are outside of open enrollment, but also outside of your qualifying life events like having a baby or losing your job or and health coverage that way or moving. These are people who are coming to us and they signed up for a so-called junk plan or health sharing ministry or didn't sign up at all. And now we're starting to see they're getting sick and needing help. So we do look at every single case in depth to find if there is any reason that we can outside of someone getting sick that we can help people. But uh, it is higher than we have seen in years past, and unfortunately, that was expected as well. But the good news is we still are a home for people who wouldn't have coverage otherwise, and we are still helping the people that we can. So appreciate all of you, and I will pause. I guess people can put questions into the chat if you need be, or you can always reach out to us, and you can reach out to me if you have any questions as well. Thank you all.
All right, looks like we're ready for the 1915 Rise Initiative update. Good morning and glad to see everybody here today. I'm Tanya Dickinson. I'm with the 1915 Rise Initiative implementation team. And I think everybody here is probably aware of the program, but just in case, slide please. 1915 Rise is a new Medicaid benefit under the state plan. It's designed for Medicaid eligible adults with serious mental illness with or without a co-occurring substance use disorder, and provides 10 services that are based in the community to assist individuals in succeeding in their community. The services range from case management, which everyone receives, to supported and housing and tenancy supports, supported education and employment, on up to non-medical transportation. Slide, please. We're really pleased with the progress of implementation to date. We'd like it to be faster, of course, but we're going as fast as we can, and we want it to be successful as we go, too. And we are now providing services as of February in 4 of the community mental health center regions. And just to be clear, those are the regions, just because folks are familiar with how the state's divided for those service areas and not necessarily the community mental health center itself. But we're in Pennyroyal, 7 counties, Kentucky River, and New Vista, so both East, West, and Central Kentucky. There are our providers that are currently certified and Medicaid enrolled or listed on the provider directory, our online one, and the instructions for how to refer someone to the 1915 Rise program are also on our website. Slide, please. Just because I'm geography challenged, these are the popped out regions are the ones where we are currently operating now. And for those of you who like maps, that's also on our webpage. Slide, please. We have over 100 providers are currently somewhere in our application and review process. 24 have submitted applications, 15 are certified to offer services, and 13 have completed Medicaid enrollment. And there's the provider directory again link. We're always looking to recruit more providers, and will be on into the future so that we can ensure that everyone has a broad choice who's a participant when they come into the program. Each region within the state of the remaining regions will open once all 10 of the available services are available within that region. That way we can ensure that individuals are getting served. Across the 4 operating regions, I've got a little bit of update. We got new numbers in, but we now have 117 referrals received, 97 have been assessed, 63 have been referred to case managers, 12 denials of service, and 15 individuals who declined services. The referral process is At the beginning, very simple. Anybody can make a referral to the program. Go to the website again. There is the referral form there, as well as links and information to questions that folks might have. Referrals can be made by family members, current providers, or the individual themselves, hospital discharge planners. Pretty much anybody who's working with the individual or is aware of the individual can make a referral. The individual goes through a initial screening to make sure that they're Medicaid eligible, of the correct age, and have the diagnosis necessary. And then it goes into an assessment period, which determines both the individual's history as well as needs that they may have that the program can fulfill. Then they are referred to a case manager who helps them develop a person-centered service plan that provides access to all of the other programs and services that the 1959 RISE initiative offers. Keep an eye out for further details and regional startups as they come online, and we'll update you here and in other informational meetings and on our website and things. And I'll put resources and the references to the websites also in the chat so you can get to them easier. But that's all I have for today. Thank you.
Thank you, Tanya. It's so exciting to hear about this every month and the pace that you all are moving at. So thank you for sharing. Good morning, everyone. I'm Carmen Hancock. I'm the Division Director for Long-Term Services and Supports here with Medicaid, and I'm here to speak with you all this morning about our newest 1915C waiver, the Community Health for Improved Lives and Development, or CHILD waiver. Next slide, please. And as Tanya said with RISE, I'm sure many of you all are aware of this, but for those who might be new, the CHILD waiver is our newest 1915C waiver. It's intended to serve children and youth with the most complex needs, and has come about and been developed in response to long-standing gaps in supports for families navigating really serious challenges with their kiddos, particularly those that might be at risk of hospitalization, residential placement, involvement with child welfare, law enforcement, that sort of thing. We did launch in January of 2026, and again, the services are intended to be they're community based, and really invest in prevention and preservation first, rather than crisis based or institutional care. So really focusing on helping our families and youth get the services that they need in their communities while being able to remain at home in their schools and in their communities again. Next slide, please. As we think about who the 1915C child waiver is designed for, these are children and youth under the age of 21 with significant behavioral health or developmental needs. And it's a child who would need a level of care like what would be provided in an inpatient facility, an ICF IID, or a psychiatric inpatient hospital. But they can be safely supported at home in their communities with the right sets of services and supports. Next slide. Some of the targeting criteria that we're looking at as we're working through potential participant applications are those who have really gotten to the point where they've exhausted the supports and services that can keep them safely in the community. Some of these items that we would be looking at would be youth who are either unhoused currently or at risk of being unhoused. They might have had various foster care placements over the recent years, contacts with law enforcement. It might be a child who is currently in an institution and is set to discharge in the next 45 days. Or it might just be someone who requires an institutional level of care, really requires that higher level of care, but they can be safely supported at home in their community with the proper services and supports. Next slide. The child waiver has 6 services built into the program. So case management, respite, community living supports, environmental and minor home modifications, clinical therapeutic services, and supervised residential. Next slide. So we have been working hard since the beginning of the year to really get our provider base up and going, working through participant applications as they come in. This is where we stand today. We have received 13 applications from providers. Of those, 4 have been certified, and 2 of those certified providers have completed the entire enrollment process and are already up and running and able to take participants and start providing services. We do have 7 of those providers, of those 13, that are still in a review process. Most of them, we've asked for additional information, so we're just waiting to get those bits and pieces together so we can keep them moving through the process. And as for participants, we have received 23 unique applicants. Of those, 5 have been approved and are at the point where they're ready to meet with their case manager and get their person-centered plans written and start receiving services. We have 16 of our youth right now that are in the process where we're needing a little bit more information from them. And 2 of our kiddos are waiting to have assessments performed right now. So really excited about the growth here. And again, just continuing to move through and work these every single day. So next slide, please. We do want providers. If you are an existing waiver provider or maybe a provider that is not a waiver provider but does focus on children or youth that might really fall into this special set of needs, we would love to hear from you. While we do have a good pool of providers for all of the services, we really want to make sure that that the services that are needed are available in the state where the youth are located. So really looking for providers. If you're interested, that is our email address that comes directly to my team, and we will work with you through that application, certification, and enrollment process. So just reach out to us. We'd love to hear from you. Next slide. I think that might be it for us. We've got resources. Yes, lots of resources here. In addition to that Kentucky Child Waiver email address, we also have our 1915C waiver help desk that you can email or call. Lots of links to different websites and resources that you can access through our cabinet websites. And then another plug here, we do have our child regulations that are currently under review. They're awaiting approval. And the public comment period for those is open through March 31st. So if you have an interest in this population or you have an interest in this program and you have not gone out and taken a look at those proposed regulations, please do so. We really want that public comment so we can make sure that we're offering the best program and the best set of services that we can to these youth. So thank you all very much. I think that's it.
So I think I am next on the agenda. Hi, my name is Marnie Mountjoy. I am with the Department for Aging and Independent Living, and I'm going to talk to you today a little bit about emergency preparedness and a grant opportunity that the department had back in 2020. So next slide, please. So part of the grant that we received, like I said, it was in 2020, and we all know what was happening in 2020, and it was just kind of coincidental that we had a disaster preparedness grant during a national pandemic, and we took this as an opportunity to do a lot of participant surveys and stakeholder engagements because seniors were at home. Seniors didn't get to go to the senior centers. They weren't going to the nutrition sites. So they were very responsive to phone calls that we made for asking them questions. And we got lots of information out of seniors when we called. But the goal of the project was to really prepare our aging network for responding to a disaster and making sure that solid plans are in place. So we had 3 phases of this project. The first project is like what I talked about, engaging seniors. So we did over 5,000 surveys with seniors, asking them about what they were doing in during the pandemic, since senior centers were closed. What kind of things were they doing? Were they sheltered in place? Were they getting the meals that they needed, making sure their nutritional requirements were being met, what were doing around social isolation, medication, those kinds of things. Phase 2 involved surveys of other states. We engaged all 50 states to see what kind of disaster plans they had in regards to the aging network, but we also interviewed our senior centers and our senior nutrition sites. So we surveyed almost 1,600 senior centers in Kentucky and also in Georgia. So we interviewed, oh, and some other states. We did some national surveys with that as well to engage senior centers to see what kind of things they were doing, what they were seeing amongst their service population. And then the next phase, phase 3, was to develop some tools that would be used for planning purposes. So next slide, please. So we developed a blueprint, disaster preparedness blueprint that would help senior centers know what they needed to do ahead of time to plan to be prepared for the next disaster. Unfortunately, as you know, here in Kentucky, we have the opportunity for a lot of different disasters. We have tornadoes, we have snow, we've had ice storms, we've had floods, we've had fires. We are potentially going to have an earthquake. We are on the New Madrid fault line, and that is something that we do keep in the back of our minds that we need to prepare for as well, for when that happens, because we can't say if anymore because we've seen everything happen over the last few years, haven't we? So we have this blueprint and this template that we've developed that lists the important things that senior centers, and when I say senior centers, yes, this was designed for senior centers, but the tool is something that you can use for other agencies. It can be used for adult day settings. It can be used in childcare facilities. It can be used in nursing homes. It's really adaptable to any kind of agency. It was just the grant funds that we used to develop this were specific for senior centers. But it talks a lot about making sure that you have staff contact information available at all times, making sure you have participant information. Do you have a participant's emergency contact? For our aging programs, we also keep track of who of our seniors are utility dependent so that we can provide the utility companies with their names and addresses so that we can prioritize those folks that might be oxygen dependent to get their utilities restored as quickly as possible. Unfortunately, we have used that a few times. We've partnered with the Department for Public Health and Kentucky Emergency Management to get resources out to those individuals. Um, Something that most senior centers prior to our work didn't really think about was making sure they had contact information for their utility companies. If something happens at a senior center and you're in the kitchen and the gas line breaks, do you know who to call? Do you quickly know who to call? Do you quickly have Columbia Gas? Do you quickly have that information available to you? The water company, the electric company, if something happens. Making sure you have contact information for your regulatory oversight agencies. So the Office of the Inspector General, the Department for Medicaid Services. Do senior centers know how to get in touch with the staff of the Department for Aging? And making sure that you have a communication plan to let your community partners know what's going on, if something's closed, if you've had to change locations. So we put a lot of effort into developing a plan. Next slide, please. Also with the plan, we developed some videos. So we have 12 short videos, anywhere from 5 to 7 minutes each, talking about different types of disaster preparedness topics, such as how to design a plan, how to have an MOU with some of your utility agencies, what it might look like to shelter in place, having that communication plan, what remote operations might look like, and then evacuation plans as necessary as well. Next slide, please. So even though we did all these things with the grant, we've seen that this work kind of preparedness it intertwines with all the work that we do. So as a Commonwealth, we participate in something called the National Core Indicators for Aging and Disability. These are surveys that are conducted amongst our home and community-based waiver participants and our Older Americans Act senior aging program participants. So it's a survey, and this is a listing of all the other states that participate in the National Core Indicators. It's an evidence-based survey. I don't know if I said that or not, but we do some sampling of individuals in the waiver program and our aging programs across the Commonwealth. And one of the questions that's listed there is, does the participant have an emergency plan in place? So we asked the participant, do you have an emergency plan? Do you know what your emergency plan is? So 68% of respondents said that they had a plan in place, but the national average is 79%. So we want to achieve, we want to be the best. We want to be better. Let's see, who's the best on here? Is that NE? That's Nevada? I'm not very good because I'm from TN, Tennessee. Let's blame my education on my Tennessee upbringing, but they're 91%. We want to beat Tennessee. So we are working on, oh, Nebraska, thank you. So we are working on developing some training for our waiver case managers and our state aging program case managers on how to make sure seniors know or program participants know that they need to have a disaster plan and what that disaster plan would look like. Next slide, please. A similar question, as a participant, are you able to quickly safely and quick, how are you able to get to safety quickly if there is an emergency? So here we're at 81%, the national average is 88%. So again, developing some training and resource materials for case managers to work with their program participants. Next slide. So part of these plans, it's really crucial for program participants and all of us as individuals to make sure that we have a plan in place, where to go in the event of an emergency, who to contact, what you need to take with you, prescriptions you need to take, any kind of medical information. My family's disaster plan is to go next door to Mr. Barry's house and report to his mailbox. That's where we're all going to check in. So it's really important that you have a plan in place with your family. It's also important to have emergency contact, names and phone numbers for people to call in the event of emergency, or if somebody can't get in touch with you, who could they call to check in with? And then we have a requirement that this is going to be documented in the appropriate data system. So this is in the MWMA system, and the training for our case managers is going to be making sure that everybody knows where in MWMA this information goes. And then on our aging side, we are also incorporating this into our state data system. Next slide, please. So we do have a page on our department website that has the blueprint, the plan, the blueprint, the survey results. If you're interested in reading, I think it's 91 pages of survey responses. We have all this information available, so and links to the videos. So some wonderful resources and tools that might be supportive to you all when making the plans for your agency, for your organization, and for yourself to when the next disaster strikes. So my contact information if you need anything, and I just thank you for the opportunity to talk a little bit about emergency preparedness.
Thank you, Marnie. That is perfect. I'm Dr. Terrio, and we're going to talk or do our spotlight today for our Healthy Kentucky Home. And we just so happen to be talking about home emergency preparedness. So next slide. As you know, our Healthy Kentucky Home is based in having healthy diets, having 2 servings of fruits and vegetables a day, exercising regularly, 30 minutes a day, 3 days a week, and then engaging with others. But we also want to talk about what our state has for you, resources to use for emergency preparedness, and talk a little bit about what you can do to make your family and your loved ones a little bit safer while at home. So next slide. As Marnie was saying, natural disasters are increasing all the time. It's not just floods, tornadoes, but just like the crazy winter weather we had on Monday, and then all the black ice we had on the roads on Tuesday. I mean, it was just treacherous. So things are getting worse and worse with the crazy weather, and you just have to be prepared to handle whatever is thrown your way. We can't control when emergencies happen, but we can control how we are prepared. You have to have a plan. And that's the important thing about taking care of your family in an emergency is being prepared and having a plan. So next slide. Part of what you want to do for your family is meet with the household members and discuss basically over dinner, or discuss what you're going to do, what to do if you have a fire, what to do if there's a thunderstorm or an earthquake, what about a flood, what if it's a medical emergency, what if grandpa is up on a ladder cleaning leaves out of the gutters and falls, and the only people at home are the 8-year-old and the 9-year-old. Terrifying, yes. Do they know how to call 911? Do they know how to stop bleeding? They're old enough to know these things. So, talk about what to do. Have people empower the family members that they can do something to help, and explain why it's important. So, the other thing you want to do is find the safe spots in your home. So we all know if the tornado comes, go to the basement. If you don't have a basement, go to an internal room with no windows, like a bathroom or a closet, something that has some structure around it to keep you safe. I said we all know that we're supposed to do this, but do we? I don't know. So you have to have that conversation, with your family members. My daughter just bought a house and moved in October, and that was one of the first things I did. She does not have a basement, and so I, found the place where she should be in case of a tornado, and I let her know that. Probably really bothered her, but that's what I do. The other thing you need to talk about with your family is when to stay and when to go. That old Clash song. So, you want to talk about this ahead of time because you don't want to make the decision on the fly. When should you shelter in place? When should you go? What are you going to need if you shelter in place? What are you going to need if you go and evacuate? So that leads us to the next thing. You're going to have to talk about an emergency list. You're going to have to make it. If you evacuate, what are you going to bring with you? What is necessary to bring with you? Not what do you want to bring? What is necessary to bring? So next slide. Again, with the home preparations, like we discussed, grandpa up on the ladder, cleaning out the gutters, somebody should know what to do if that happens. Now, what are you going to do? You're going to call 911 and you're going to attend to injuries. So people need to know what to do. Somebody hopefully will take a basic first aid class. If suddenly a pipe bursts, and it's not a natural disaster, but a pipe burst, you're going to have to know how to turn off the main water source to the house. How do you turn off the main gas source? Different things like this. Again, teach your kids, call 911. When is it appropriate? When it is not appropriate? The kids also need to know the full names of their caregivers. Again, what grandpa falling off the roof, you got a 7-year-old and a 9-year-old, what's your grandpa's name? Grandpa. Oh no, what's his real name? Grandpa, so they have to know what is his name. His name is Milton Brown, so they need to know this information. They also nobody knows telephone numbers anymore. I don't. It's all in my phone. So what if I don't have my phone? Or what if the phone's dead? I couldn't call anybody. So you need to have somewhere a list, but not in your phone, written down about, people's phone numbers, emergency contacts, different pharmacy numbers, physician numbers, things like that. We ask people to post that on the refrigerator, and first responders are taught to look on the refrigerator to see, find a list of emergency contacts. They are taught that. They don't find it very often, but it would really help them out if Grandpa fell off the ladder, that they can go and look at the emergency contact list and call somebody and not rely on the 9 and 7-year-old. So next slide. You really should have a transistor radio, something that runs on batteries, with good batteries or replacement batteries, but something that can work without electricity, so you can get information, what is happening. If all the internet and the power is out, how are you going to find out what's happening out there? You can try and draw a floor plan to the house and list different ways to get out of each room. If it's upstairs, like in my house, and you only have one set of stairs leading down, how are you going to get out if the fire is on the stairs? So you might have to think about having emergency escape ladders upstairs. And if you do, when to use them and how to use them, because it's usually little kids up there. If you have family records, so security cards, immunization records, passports, things like that you keep at home, they should be in a water or fireproof container. That you should have several fire extinguishers around the house, in the garage, in the kitchen, in case you need them. And then making your checklist for evacuation, an evacuation kit. So next slide. So when you're thinking about an evacuation kit, the list is more important than the actual physical kit, but you need to be ready to leave within a 5-minute notice or less. So if you're making a kit, it needs to be like a backpack, something easy to carry. It should have your battery operated radio, if possible, medications. If obviously you can't store medications in a kit, make a list. And so when you don't have to think about them, you just get things on the list and put into the backpack. If you have change of clothes or shoes, you don't want to. I always imagine if something happens, I'm going to run out of the house with no shoes and in my pajamas. So you need to be able to get these things together fast so you can escape. Ideally, if you have a little bit more time, water and non-perishable foods like canned foods. If you do that, you need to have a can opener, blankets, sleeping bags, things like that. So next slide. In that emergency kit, a first aid kit is important. We talked about the medicines. Again, you're not going to physically put your medicines in this kit, but you need a list of every family member, what medicines they're on, how often they take them, why they take them, and what pharmacy they get them from. Because if you have to evacuate, you're going to have to get those medicines fast, and you're going to have to know the pharmacy number. Now, with Medicaid, we will make sure you can get your medicines replaced right away following a disaster. But you don't want to count on that. So you want to plan maybe a couple days without the medicines. What do? I need this information. Again, if there's a fire, you don't rely on others like the doctor's office to have your list of immunizations. They probably do. The registry, the state registry probably has them, but again, don't rely on that. Try and keep that stuff with you. If you have older individuals, or I guess younger, that have any medical devices like a pacemaker, you need the information on that pacemaker too, if you can. Just the serial number, things like that. Or baclofen pumps, when was it last filled? Are you at risk of running out of that medicine during this emergency? And if you have any, again, older members or infants, do they have special food needs? Do they need diapers? What else do you need to bring with you for that individual? Also, if you're sheltering in place, you're going to use all of this stuff too. You're going to have what you need, and you're going to know what you need. So next slide. nice to have things additionally in the kit. Again, you can put this on your list. Charging cords, batteries, things like that. Very important. I put cash on here, and I know you all are thinking, well, gosh, I haven't used cash in forever. But during Katrina, nobody had electricity, so you couldn't buy anything with a credit card. They also didn't have, internet or Bluetooth or things like that. And so the only way to buy things was with cash. And that was a problem because even back then, a lot of people were not using cash. So think about that, or at least a way to get cash if you don't have cash on hand. Next slide. And then Marnie was talking about this. Pick an in-state and an out-of-state relative or friend that if you are separated from your family members, you can the kids know to contact. And so if you can't contact your kids, they know to contact this other person, and you can contact that other person, and you can get your family together. And also have a spot close by. What if a tornado comes through and takes out your house and takes out the neighborhood? So where are you going to meet your kids? Have a plan. Oh, I'm going to meet them at Highlander Point at the Dairy Queen. So they all know when to do this in case of emergency to get back together if you can't talk to them. Next slide. Your emergency kit will work if you shelter in place. So, the water, the food, the clothes, the blankets, it's easier. You don't have to bring all that stuff with you, but you still need the radio, the batteries, the charging cables, diapers, if people in the house use diapers, medications, and you're going to have to be able to call, have access to these phone numbers without your phone. So a list of phone numbers of important places and things to call. Next slide. And, this is a disaster. This is a big deal. This is a crisis. So it's okay not to be okay. I just wanted to remind everybody about our 988 phone number that you can call for a mental health crisis. So don't be afraid to ask for help. Call 988 sooner rather than later if you think you need it or a family member needs it. And this is one of the resources that we have following a disaster or an emergency. So next slide. We also have some other great things. I don't know if you knew about this, but we have the Kentucky Medical Reserve Corps. They have a lot of trained volunteers that will go out for a disaster and provide help, knowledge, supplies. Very important. Their website is here. And next slide. We also have the Kentucky Emergency Management Plan and Prepare Corps. So these guys are prepared. They can help. They can send people out, and you can contact them if needed. And next slide. And there's a list of a bunch of resources if you need them. The slides will be put on our website following the presentation today. So you're not alone. You can have all these resources, and you can get prepared and be confident that you can take care of yourself and your family and your loved ones in the case of an emergency. So thank you. Next slide. There you go.
Thank you, Dr. Terrio. I noted a couple of things that we need to do in our family. So it's a great reminder, and I hope that was helpful to folks. Let's move on to the next slide, and we are starting to get a little short on time. Some of this is repeated information from previous presentations in the monthly forum, so we won't spend a lot of time on just some of the repeated information, but I know it's always great to hear things multiple times to learn. That's how I learn. So just a reminder, we're talking about HR 1, and it has various names, including One Big Beautiful Bill, Working Families Tax Cut. But basically, we want folks to know that there is a new federal law and new federal requirements for Medicaid eligibility, and it impacts adults having to work, go to school, or volunteer. When the Medicaid agency has to check eligibility, and then cost sharing. Let's go to the next slide. Community engagement. What is that? It doesn't it might not sound familiar or understandable, but basically, community engagement, as contained in the new federal law, is about a Medicaid member, certain adults, and we'll discuss who those are, that they must have 80 hours in a month doing one or more activities. And that includes working. It could be job training or a workforce program. They could be enrolled in an educational program, including maybe still in high school or in a GED. And they could possibly be volunteering for a community organization or a nonprofit. We just want to remind folks these are new federal rules and states are required to implement them. These requirements start January 1, 2027. So after that date, the folks that are required to demonstrate community engagement, once anyone who's a new applicant, so anyone who applies after January 1, 2027 will have to, and then upon a member's renewal that may be subject to it, might have to comply with it, will have to demonstrate it. Next slide, please. So who are we talking about? This is the expansion population. You probably have heard us talk about them before, but just to let you know who they are. They are adults that are ages 19 to 64, and they're enrolled in Medicaid because of their income. So they don't have some other reason or qualify for Medicaid for some other way. And just based on their income, up to 138% of the federal poverty level allows them to enroll in Medicaid and be covered. So we're talking about that expansion population. But there are people who may be considered expansion, but then also might have a reason why they're excluded from these requirements, or have an exemption from them. A couple of those include they might have a disability. And veterans with a total disability rating also will be excluded from the requirement. Maybe the member becomes pregnant or is in their 12-month postpartum period. So that expanded member would no longer have to meet those requirements during those periods. Maybe they're medically frail, and you're going to hear us use that terminology because that's what the federal law says. So we want to make sure people understand what that term means and how it's used. But basically, it means somebody has some serious health condition that also will exclude them or exempt them from the Medicaid community engagement requirement. They could be caring for a child that's age 13 or younger, or a disabled person. So they're the caregiver for either of those. Like I mentioned, if you're in Medicaid based on another category or for another reason, then you are not subject to the community engagement requirements. So anyone who's in what we call fee for service, so in a 1915C home and community-based waiver, they are not subject to community engagement. Perhaps they're enrolled because they're in foster care or a former foster care member. They are not subject to the community engagement requirements. If they're meeting SNAP or TANF work requirements, they will not have to also meet Medicaid community engagement requirements. Just meeting the SNAP and TANF requirements makes you automatically compliant. And then there are others. We're waiting for Centers for Medicare and Medicaid Services, CMS, to provide us a lot more guidance about who is covered and who isn't, who can be exempted and who can't, and who is excluded and who isn't. So we're going to be updating that information and really trying to make folks understand so that as this approaches on January 1, 2026, that folks are in a good position to try to understand whether it applies to them and what they have to do to meet it. Next slide, please. There are other HR1 eligibility changes, and that includes the eligibility renewals, the time frame. currently, as I spoke earlier, that it's 12 months. Those in the expansion population will go to every 6 months. This is starting after January 1, 2027. So as the renewal comes up, there will move to a 6-month renewal. The coverage start date, and what that is that look back period. So if somebody enrolls in Medicaid, we can sometimes look back 3 months prior to their application to see if they were eligible and they had, for example, medical bills, we could potentially enroll them back 3 months. There's a change in the new federal law that it can only go back 1 month for the expansion population and only 2 months for everyone else. So the rest of the Medicaid population is impacted by this. That also begins January 1, 2027. And then non-citizen eligibility. So the new federal law makes changes to who in the non-citizen groups can be eligible for Medicaid. That change begins October 1. And I'm sorry, that should be 2026. Apologies for that. That should be October 1, 2026. So that is coming up this year. We are currently trying to identify who those are. CMS just recently put out guidance and are answering questions from state Medicaid agencies to help us fully understand how to implement this change. So we will continue to provide more information about this, including who is impacted by it and how we're going to handle that implementation as we approach October. And again, that's October 2026. Next slide, please. And then the last one I wanted to talk about was cost sharing. So this is in the federal law required after October 1, 2028. And it does mandate cost sharing for that expansion population again. There are some differences in terms of what can be implemented. So the cost sharing cannot exceed, and cost sharing is copays, cannot exceed 5% of a member's income, and also cannot be charged for certain services like preventive services or mental health. Those types of services are exempt. So again, as we approach that October 1, 2028 federal requirement, we will be letting folks understand what that impact's going to look like. Next slide, please. Now we are at time, but I wanted to quickly just go through how we're thinking about implementation. We've broken it into three work streams. There's the policy, IT systems, and communication. Next slide, please. So for policy, here are some of the steps that we're looking at, and you will get access to these slides and you can go back and take a look at it. But primarily, we're right now talking about what are the policy changes, what are the rules. There's a lot of questions pending before CMS for states to be able to fully understand the changes and how they're going to be implemented. But right now, so we're trying to understand those and see what needs to change within the program. And so we're working through those right now. Next slide, please. For the system changes, a lot of things in progress, and future next steps, because that all is happening as we understand what the policy changes are. We are starting to meet on the system changes and talk through what the system does and how it navigates, and how somebody who is coming in, how they're going to navigate the process. Next slide, please. And then communications. And I want to spend just a little bit more time on this because we do plan and are planning for a lot of outreach and communications around the changes. We have been planning for frequently asked questions. We're going to have fact sheets that are population based. One pagers on various topics that are incorporated, like that 6-month renewal or cost sharing, specific one pagers to those requirements. we're going to have toolkits, not only for our members, our advocates, community-based organizations, providers, for anyone who's going to try to help a member navigate what the changes are. We'll have toolkits for them. And we plan a lot of social media and promotional materials around what's happening to make sure that folks understand it. And then, of course, the member outreach and notices. So we are in progress with creating a communication plan and communication materials. We've got a fact sheet that we're working on, and we hope to post that soon after it goes through some reviews. So there's just letting you know that we're kind of being thoughtful and intentional about how we communicate the changes. Next slide, please. We do have a stakeholder engagement plan, and so we'll be sharing on this meeting as we finalize and issue communications. But we do plan to have various ways of folks, including and in particular Medicaid members who have that lived experience. We're incorporating their feedback and into what we're doing. So we do have the Medicaid Advisory Committee. We have the Beneficiary Advisory Council. We're restarting the Notice Improvement Work Group, which was a work group that helped us in fine-tuning some of our notices to make sure that they are member-friendly and easy to understand. And then for the IT side, we're going to have focus groups. And again, those Medicaid members are participating in those focus groups to take a look at what we're doing in the design and development of the system and try to get their input to see if there are ways to make it easier for them to navigate. Next slide, please. So our next steps, we are working on regulations, reviewing to see if there are any changes needed in our statutes, in our state laws, and definitely in our policies. The system design sessions are happening now. We're creating those public-facing materials, and we will be doing a lot of engagement and working with Medicaid members and others who support members navigating the system to make sure our communications and the system reflects their input. Next slide, please. And this is we wanted to start letting folks know about opportunities to further learn or engage in Medicaid. So here are some upcoming meetings in April, just to make you aware. And these are all public events that you're welcome to join. Next slide, please. And our call for a topic. So if you have a topic you really like us to provide information on, please be sure to let us know what that might be. And we again appreciate your time. Thank you for hanging out with us as we went over a little bit, and I hope you have a great rest of your day, and we'll see you next month.